Assalamu alaikum. We're starting our long clinical consultation day with Miss Hala, 22 years, came with complaint of short of breath. You are the medical doctor and examine the patient. 2 minutes, or I will share the timer, then we can start.
Okay.
Okay, ready?
Yes. Hello. I am Dr. Mitwalli. Doctor covers the clinic today. May I confirm you are Mrs. Hala, 22 years?
Yeah. Hello. Yes.
Okay. Nice to see you, Dr. Miss Hala. I am here today to listen to you, and may I need to examine you? Is this okay with you?
Sure, doctor.
Okay. From my note, I found that you have some shortness of breath. Can you tell me more about that?
Yeah, doctor. I'm quite. I don't know what happened. I woke up like that today, and it's came on recent with me. I'm quite afraid, doctor. I'm quite afraid.
I'm sorry for you, Ms. Hala. And can I offer to you any oxygen if you need?
Yeah. Thank you. No worry.
Okay, Ms. Hala. So you are first time to wake up this morning by this problem in breathing?
It's actually worsening with me since the past 7 days, but today I become really worse.
Mm-hmm. I'm sorry for you. I'll try to help you today.
Yeah.
Shortness of breath start 7 days ago.
Yeah.
Do you have any like high temperature these 7 days?
Not really.
Mm-hmm. And did you feel that you have any cough these days also?
Yes, I have cough also.
Mm-hmm. So this cough have any belva?
It's dry.
Mm-hmm. And is any blood coming with cough?
No, never.
Okay, and this cough for 7 days only?
Yeah.
You never have cough before for a long time?
No.
You have no allergy?
Well, I'm not sure if this is allergy, doctor, or not. I'm not sure what's happening.
Yeah.
Because I'm
Before
also
you have no
wheezy.
allergy.
I'm also wheezy, and I hear wheeze in my chest.
I'm sorry for that. And you hear this wheezes only these past 7 days?
Yeah.
Mm-hmm. And before you have no noisy chest before
No,
this
I
7
don't
days?
have. I don't have, never.
Okay. Do you have any chest pain?
I have, yes. I have pain, especially when I'm breathing in. All my chest, like when I breathe in, it becomes worse. It's like stabbing.
I'm sorry for that. Can I offer to you any painkiller
Thank you.
if you need?
Thank you.
Okay. And do you have any awareness of your heartbeat?
No.
Okay. Do you have any dizziness?
Well, I have dizziness long time. It's not now only. Like I have this dizziness long time. I can't remember.
Okay. And this dizziness, like from when you come from sitting position to standing position, or you
Yeah,
didn't know?
I'm actually diagnosed with Addison, doctor.
Is this for
So
how
I have
many
this
years?
dizziness, and I am now controlled with. I take steroids. I'm controlled with that. I don't
You
have
take
dizziness recently.
For how many years you take it?
I take it like since my childhood, doctor. Doctor, my dizziness came on worse now with my this illness now again.
Okay.
Yeah.
You found that this shortness of breath is increasing in any situation, like when we walk?
When I can't walk, this my shortness breath now is coming with me even with I'm lying down. It was with I work, yes.
Do you feel any increase in it when you lying at the bed?
No.
Do you need to use many pillows this last
No.
days?
No, I'm fine.
Okay. Do you notice that if you bend to the front, this make some relief to your shortness of breath?
I don't understand the question.
If you bend forward, this make you have any
No.
relief?
No, it's not related. I don't have that.
Okay. And if was apart from Addison, do you have any medical condition? You take medication
Yes.
for it?
But we have in the family, in the eyes, we are blind. We have like something called atrophy in our eye nerve.
I'm sorry for that.
Yeah.
And
I
do you
have
take
thyroid,
any
low thyroid.
thyroid?
Low thyroid. Even when I was diagnosed with Addison, also low thyroid, lazy thyroid.
And you take medication for this
Yeah.
thyroid?
Yeah.
And you are compliant for both steroid and thyroid?
Yes, I'm
thyroxine.
compliant. Yes.
Okay, and any change recently in the doses?
No.
Are you take any medication apart from those two medication?
So yeah, I am on hydrocortisone 5 milligram in the morning and night, and I take thyroxine, and that's it. I take sometimes painkillers, and that's it.
Okay, any surgery before?
No.
Any edema in your lower limb?
No.
Okay. Apart from family history of this problem in your eye, do you have any family condition running other than this?
No.
Okay. Any family condition like cardiac problem or chest problem?
No, doctor. No.
Okay. Do you smoke, Miss Hala?
No. I'm very clean. I don't smoke. I don't drink alcohol. Never.
This is good. It's nice. With whom you live?
Well, I have a carer with me at home. She is my mom also. We are fine. She is fine. Yeah.
And you need any support or any interfere?
No, I'm totally fine now. Thank you.
Okay. And are you studying or any?
Yes.
You have any
Yes.
job?
Yes, I'm fine. I'm trying to study. I'm in college. I'm doing well.
And I need to ask you some private question about your menstruation. Is this regular? Any problem in?
It's becoming well, it was really affected, but I don't think I can have a period since I'm childhood, because they said my problems is mainly from the main gland in the brain. So that was diagnosed long time ago, and I'm on supplement for that. I'm on thyroxine and I'm on the steroid. That's why I have the Addison and both the thyroid.
Yes, I am sorry for that.
No worries.
Okay, do you notice any weight changes in last days?
No, I'm fine.
Okay, do you notice any sweating at night?
No.
Okay, do you have any joint pain?
It's my like the body is ache. Yeah, I'm like tired recently. Yeah, like ache.
Yeah, I understand, and I'm sorry for you.
Thank
So
you.
you feel fatigue also?
Yeah, just
Mhm.
recently.
Okay, any skin changes you notice
No,
or anyone notice around you?
no skin changes.
Sorry for asking. So you are now completely blind or you can see?
I completely blind, but she
Mhm.
has her mother with her, so she can help you.
Mhm. Okay. Okay. For about do you have any headache?
No. Well, slightly in the front of my face, you know. My nose is slightly full also.
Mhm. And any weakness anywhere in your body?
No. I'm totally like my whole body is weak just recently.
Yes, yes, I'm sorry for that. And do you notice any pain in anywhere in your body, in your muscle, in your back?
No, I'm fine, doctor. I'm fine.
Mhm. And can I ask you if you have recently traveled anywhere?
No,
Do
good
you have
question.
any diving anywhere or
No,
climbing like
no, no,
high altitude? No?
no. I'm just home and then school and that's it. And college and home. Yeah.
Okay. Um, do you have any throwing up or being sick?
No, no.
Difficulty
I
swallowing?
no. I have wheeze, doctor. Sometimes in these 10 days, 7 days. Um,
Mm. Okay. Okay. Some cough and wheeze?
yeah.
Mhm. Okay.
Okay.
Any change in your water work?
No.
Do you feel any your water work like frothy or any change in color? Any blood?
No. Normal.
Okay. Uh,
Mm-hmm.
okay, may I examine you?
Yeah, yes, sure. You will
Okay.
find a slightly overweight, like cushingoid appearance, but she's like slightly from steroid, likely. Yeah, but she's fine, like she's
Is
fine.
any paleness in conjunctiva?
No, she's not pale. She's slightly short of breath, but she's not pale.
The pulse is equal bilaterally, no any change in pulse. Pulse is normal.
You will find this lady. So imagine you have this lady in examination in the WhatsApp group. The pulse is normal. Okay. Well, the pulse is around 90. You can say 95. Hello, Amir?
95?
Yeah.
Okay.
Mhm.
And I like to examine the hand. Any tremor?
No. There's no tremor.
Any clubbing?
No.
One color. Any deformity?
No.
Okay, I like to examine the lymph nodes in the neck and the thyroid gland.
Normal.
Normal. Okay, I like to examine the chest.
Yeah.
I'll see
What in the chest?
expansion.
You see, she is overall weak. She's tachypnic, and you hear wheezes. The chest expansion is normal.
All over. Can you answer the other voice because I can't hear good?
You can't what?
Can we mute the other, please, Dr. Basim?
Yeah.
Okay. There is wheezes all over the chest, huh?
Yes, the chest expansion is normal.
Yes, and there is no added sound other than wheezes.
No.
Okay, and no any area with no respiratory sound, yeah, breathing sound.
No.
And the pulse and the cardiac examination, I need to localize the apex and listen to it.
hyperdynamic S1, S2, but like hyperdynamic circulation from the acute illness.
Okay. I like to see the lower limb edema. If there is.
Normal.
Okay.
Yeah.
So, what's your
Timer,
concern,
Dr. Wilson.
Ms. Hala?
Sorry. Yeah, so yes, what I have, please help me.
Okay, Mrs. Hala, from you tell me, and after examination, I think you have some condition in your
2 minutes, I mean.
yes, in your chest, maybe relating to your weakness and
Yes. Weakness?
I don't know really.
No, you have
Dr.
time.
Aisha, yes.
Yes.
By the way, if you're stuck with diagnosis, don't give definite diagnosis. You can tell here you have some chest problem, and we have to do some 1, 2, 3, 4, and
Yes.
see another concern. Be smart in the answer. Okay, don't give diagnosis. You don't know, right? So try to
Okay,
give
because
like
I am not good in
it's
syndromes,
okay.
really.
No problem.
No,
Leave
it's
it.
not.
Leave it.
Imagine
Don't.
that acute chest problem purely.
Yeah, don't be stuck. Try to
But
give
no any
any.
constitutional symptoms on any.
Okay, what I said now. Till here you have some chest problem. We will admit you and we'll run some investigation image and blood work up to find out what's the main problem. That's it. Don't give a name because you don't know. But you don't be quiet and silent. Okay. Now
Okay.
answer his concern.
Okay. Okay, Mrs. Hala, we need to run some tests for you and to take a scan to your chest so we can know exactly what is the problem with you. But for time now, we will help you about this pain in your breathing and about this shortness of breath by some oxygen and some rest at bed, and we will provide you with some medications that may help, like nebulizer. This will help you slightly till we know exactly what is wrong with you. Do you have
Very
any
good.
other concern?
Thank you, doctor. Thank you. No worry. Very good. Okay. So
Okay.
Yeah,
Any other-
great. Now the examiner time.
yeah.
Okay.
So tell me your findings in Miss Hala.
Okay, Miss Hala is has shortness of breath associated with cough for 7 days. She has also chest pain, especially with breathing. She has a history of known optic atrophy run in family, and she also known to have done hypopituitarism, and it is may be also hereditary condition or genetic condition, as it started from childhood. He also has some cough and with chest. I can't appreciate that she has any history of travel and any history of constitutional symptoms and any red flags for
what is your differential diagnosis?
Okay, this patient most probably maybe has some maybe asthma or maybe chest infection, maybe pneumothorax also, and also
pneumothorax. There is no trauma.
Yeah.
Okay. What is the third?
Also can be effusion or
it's
so effusion,
yes,
and
it's good. You
pleuritis.
said asthma, you said infection, very good. But she has chest pain. What also can be the?
Yes, also cardiac failure can come with it.
Okay, what is your approach? How will you manage her now?
We will keep this patient admission for till reach the diagnosis. We will run for some investigation for basic investigation, CBC, CRP, SR, and kidney function, renal function, and also chest X-ray, blood gases.
Before that, she is, yes, blood gases. Okay, yes, okay.
And also we will take, we will also check for ECG and may need echo. And
yeah, before echo, she needs urgent something.
CT.
Yes, to exclude what? Okay, she has, yeah. So okay.
BE.
Yes. Okay, so good, very good. You said good differential. So this patient has been started on antibiotics and she improved. So what do you think then the diagnosis?
Okay, diagnosis chest infection, any improved?
Yes. Yes.
Chest
Okay.
infection. Okay.
Okay. Okay. And okay, what are the possible things that if you need to ask the patient again, you need to come and ask more? What are the things?
If she still has any pain on breathing, or she has any blood on coughing.
Things you didn't ask. So things
okay.
related to her shortness of breath.
Related to,
yeah.
If she still has shortness of breath, and if she has heart racing or awareness of heart beat, maybe if she has, if she feel she can't lie comfortable at bed when in supine.
Okay, that's fine. What other investigations you want to add? So yeah,
I would like to check her condition about cortisol, so electrolytes. It is a must, and TSH, and also I need to check
to know the acute illness reason. What else?
For the reason of shortness of breath.
Yeah. You said chest infection, so how to know the cause?
Okay, we will make aspirate if not improving, and there is CRP high or YPC is high.
Okay.
Aspirate other things for chest infection.
Urine for atypical, for urine for pneumococcal and atypical organisms. Okay. So yeah, you did well. Okay. So first of all,
okay. You're done, Dr. Abdullah, for the question. No more questions.
Yeah.
Okay, let's read the comment first. Yeah. Go ahead.
So she's this is 22 years old female. So presented with shortness of breath, acute history with symptoms of related to the stuffy nose and local symptoms, could be explaining a prodrome of with dry cough, prodrome like the stuffy nose and the little sore throat there is. That predisposed to a pneumonia or chest infection, as you said, because acute illness. But in this case, we should exclude pulmonary embolism, so we should ask of symptoms of the risk factors of the Wells score. So the questions of the Wells, you asked about hemoptysis, but you didn't check the immobility in the past, in the recent. We need to check if you asked about travel. we need to ask about the history of cancer and malignancy and surgeries. You asked about surgery. Also, because she's short of breath, we need to ask about all the shortness of breath questions. So like the as you said, onset, progression, duration, worsening, and improving factors, and then there are associated. You asked about the cough. You asked about the cough. You asked about the travel. You asked about any palpitations, cardiac history. You asked about, but also we need to ask about home conditions and whether are there pets at home. And also if there is contact with any sick other, especially coughing person or any other person with respiratory symptoms. You are right that she is, by the way, she takes steroids, so she is immunocompromised considered, and that is a predisposed risk factor for her for getting an infection.
But I see it here.
Atypical infection because she doesn't have fever, as you noticed, because she takes steroids. So PE should be in the differential because of the pleuritic chest pain. First should be excluded, and there is infection, and there is you need to ask about the questions of so she is also wheezy. Actually, there are a lot of distractors. You are right there, but it's the priority. I think the priority BE because the history is short, so infection is possibility again, and also third differential could be shortness of breath, but you didn't check due to you thought of the weakness, but you should check the reflexes again. It's important in this patient. If there's areflexia, you think of then the Guillain-Barré making short of breath, which is very serious, but her reflexes are normal, so it's not in the differential. I think that's it, the case, yeah. So investigation-wise, baseline investigations, and there is the specific investigations required. So baseline blood count, looking for any anemia, white blood cell, looking the inflammatory markers, and including the CRP, the C-reactive protein, and the ESR, if there is any sinister inflammatory conditions, and also looking for specific investigation, kidney function test, if there's any associated acute kidney injury with the acute illness, or liver function test if the patient has impaired liver function from either cholestasis or raised liver enzymes. I'm not sure what is the judgment and why the liver enzyme, I need to check. But also the chest x-ray to check if there is, very important, if there's any consolidation, and she needs a repeat chest x-ray according to clinical judgment on the following days on the follow-up. CTPA is of crucial importance to exclude BE, and it's excluded in her case. And so we need to check for any infection. So when you think of infection, so you need to also, so if the first tests are negative, then we need to run, as you said, sputum culture and sensitivity. And if that is not useful or normal, then also a test for which is in some cases you think of atypical infection. So you think of Legionella in some cases. You think of also pneumococcal antigen in urine. And what else? I think I'm not sure if I forget something now. Yeah, in addition, as you said, with the hormone profile, you need to check the cortisol, Actually, she had Addison. Addison. So in your diagnosis, I forgot also to say the blood pressure. You didn't ask me. The blood pressure was low, and she had Addison crisis in top of her, predisposed by her infection. So she needs doubling of her steroids, and also she has you need to check on follow-up cortisol in the morning, and also we need to check of the thyroid status, although in acute illness may not be useful. I think that's the case. That's totally the case. Yeah.
Okay, thank you,
Okay,
Doctor.
thank you, Dr. Abdullah, and thank you,
Can I
Dr. Aisha.
and also
Yes.
please for patient with Addison and take steroids, this steroid will not cause immunocompromise and will not cause cushingoid, because it is just you will adjust it to be just compensation of his own steroid.
Yeah, replacement. Yes, replacement.
So not consider this patient immunocompromised, we not consider him to be any cushingoid feature on him, but you will find Addison feature on him, because even if you compensate, you will not compensate all. Even you may need fludrocortisone. As you said, he may, if he take hydro, he also has hypotension and dizziness when coming from sitting. But never this patient has cortisol over in his symptoms.
Yeah,
Like-
I agree. Maybe I'm mistaken in the cushingoid thing. She may not be cushingoid.
No compromise. And
But there was
about
no fever. That
immunity
explains
and
the steroid.
to the test, I think there must be some fever, some high temperature to be a key. I don't know why any fever for this patient for 7 days infection, and to a point that he has generalized wheezing in his chest. So bad infection, not localized to pneumonia, lobar pneumonia like. And so he for a point to be shortness of breath. I should be if dry or okay, some organisms have dry cough, but for no fever at all for this patient, I think we didn't find it like this patient without fever and bad infection like this. I think because the infection from my mind.
I'm not
Yes.
sure. I think to read the like, is that a case that is regarding judgment, but she really didn't have in her history in the past, and then later on, I think she developed in the hospital.
Has no sign of fever. This is the exception maybe. And because if I had extractor in the case, I miss the case always.
Oh.
But
No, it's okay, Dr. Aisha. The case was
You did
also.
well.
Yeah, you did well, but the case was not clear because,
It was vague.
as you said, yeah, it was vague because no signs of infection like fever, and no also night sweat. So it's distracting you as you was distracted by these things. Anyway, the lesson from this case, how to find differential when you are not collecting the data. You can give some differential for the acute short of breath, as Dr. Abdullah said. You can think about the possible cause for acute short of breath, which are, for example, pneumonia, but you can say against pneumonia, no fever. You can mention also PE, but against PE, no signs of DVT and no previous clot or blood clotting. Then you can give also like asthma exacerbation, but against that, no previous attack for asthma. So you can give the examiner that the idea that you tried your best. However, the case was difficult and it was vague case. So this lesson for you. All of us also should be learned from this, because you might be in the exam and you don't find the clue and you'll be more stressed. Don't be panic. don't be panic, because if you be panic, the whole discussion will be like failed. You will not answer, you will not find differential, you will not also address the concern, and I think you will lose the case. So what you can do, just address the concern, be quiet, calm down, and try to address the concern by diplomatic answer. You have chest problem, which can be related to some disease I'm not sure about. We can run some blood work up and image or scans to find out what's the main problem. I will update you after a couple of days or in the next meeting or after the collection of the result about your diagnosis. That's it. But to say I don't know, I'm lost. So what will happen? What do you think? You will lose the case. So at least give some clues or some answer that it will be like diplomatic answer, and it can give you half the mark. Then when the examiner asks you, you might say the differential, and he will give you the full mark when you give the differential or second one, for example. If you said PE, then pneumonia, you will get the mark, full mark. If you answer the pneumonia, and he will take you to the topic of pneumonia, how to manage, how to investigate, how to approach. So please don't be panic. This is the lesson, and try to find out any differential and to address the concern for the patient by smart way. Regarding your analysis of the complaint, I think you didn't analyze well the short of breath. This is for the comment from my side. You didn't ask what was the symptom, I mean the short of breath, what's improved. Is it related to sleeping at night, any
I asked
timing change?
I ask all this.
I think you jump from the chest symptoms to the I think you ask another like chest pain or something
I asked
else.
both systems, but I analyzed the shortness series food. I asked about exaggeration and specifically about something like walking and like
Okay.
supine impact, and also for
Okay.
relieving.
Okay. So the social also you ask for the family travel, and there is also a strange family history of I don't know what's the eye affection and what the relation between eye and what this syndrome, Dr. Abdullah. This question for your family. This is related to the family history.
Actually, guys, this is just a patient with pituitary hypoplasia, but she presented with totally unrelated issue. That's the thing. So in Irish,
Okay.
they present also cases which are like with too many comorbidities and not related. But I'm sorry if I confused me.
Okay. Yeah, because even me, I didn't correlate the pneumonia
No, there
to
is
the
no
main.
correlation. Just I think she takes steroids. That's more
Okay.
likely predisposed her to.
So
Yeah.
you can say that the pneumonia after upper respiratory tract infection, for example, complicated.
Yeah, she had upper respiratory tract she has upper respiratory tract symptoms when she came, and that's suggestive of a related. Actually, she was the typical history of streptococcal pneumonia, but it was found streptococcal pneumonia. But in the following days, it was not clear on the first day. So it was as you said, the differential BE chest infection. You did great. So nothing was clear in the first day, but infection was on the top differential because of the short history, and she takes steroids. So maybe atypical infection. That was the impression.
Okay, so let's go back to the comment. The job smoking alcohol, you cover all these points, Dr. Aisha. But the HIV, I think you didn't cover the HIV risk. Did you ask about all HIV question or factors like needles,
No, but
shaving needles?
when she said no period and no hormones, so I suspect it's not. I don't
Okay.
know.
Anyway, when you
She
have
like
any patient with infection.
and no time. I didn't do systematic review because no
Yeah,
time.
you didn't. That's why I told you you jump from system to system. And please, before asking about the period or the female history, try to be sorry for this type of question, okay? Because
Yes, I tell her I'm sorry for before.
no, you didn't. You said about your menstruation and you went through this this system. Anyway, anyway, the case, as I said, it's like little bit vague. So the pneumonia and the paces, it's common one, but they will not bring pneumonia without predisposing factor. For example, travel history for Legionella, okay? Exposure to some sick patient like TB or whatever. HIV patient complicated with any type of opportunistic infection or BCB pneumonia. So it's like a major topic, not only pneumonia with no underlying cause or exposure or I don't know why this patient immunocompromised to have infection or pneumonia and what category of pneumonia she has, either community acquired or hospital acquired pneumonia. So I think it will be more clear than this scenario. This is my opinion. In the exam, the cases they bring, it's not in such way vague. So we hope so also. Hopefully the case will be more clear. Don't forget to ask about travel history. If you miss this question, you might lose the case if the Legionella is suspected, for example. I think this is for the travel. The chest symptoms, you ask all chest symptoms and chest relevant system, I mean, the question for sure. Cough of blood. Also, the DVT is very important, either from travel to ask about long travel or any swelling or any previous history of blood clot. This is a very important question. Just to think about PE and DVT. Okay, try to screen for DVT in any chest, acute chest pain or acute short of breath, either by travel or history of blood clot, either from thrombophilia or from SLE, APLA, antiphospholipid antibodies. So it will be there if there is PE, I mean. Pneumothorax, okay, you can put if there is trauma or history of spontaneous pneumothorax previously. It's also very important to know, but it's not wise to give pneumothorax in such case. Why pneumothorax in this patient? Unless there is pneumonia, for example, patient intubated, some relation between pneumothorax and the consolidation or the ARDS or pneumonia itself. Otherwise, it will not be pneumothorax. Unless, as I said, there is some relation to the pneumonia or the patient already has some collagen disease like Ehlers-Danlos or Marfan or something related.
Because I
But it
suspect
will
it
be,
is syndrome, like so I
yes, I
suspect it's
agree,
pneumothorax.
but it will be also with previous attack of pneumothorax, and the chest pain will be more severe. And you didn't ask about the chest pain scale in this patient also, by the way. It's also very important to ask. Is it related to and the site of the pain? Is it chest? Is it lung? Is it pleural? You should analyze all these things. Whenever you find a positive complaint or positive symptom or sign, you should analyze it more to reach to the possible level. Okay?
Yes,
Thank you,
okay.
Dr. Aisha. I can see a lot of comments. Okay, before reading the comments, can you write the case for Dr. Abdullah in the chat box? Sorry, Dr. Aisha, I mute you by mistake. Okay, I hear some sound or echo sound, so you can write the case in the chat box. Let me read the comment as much as I can. Okay, chest infection history with Addison. She doesn't double the dose of corticosteroid, so she had Addison symptom. Okay, but patient, okay, yeah, the hypotension you mean, okay. PE but also the PE. Why PE with this patient? Vasculitis. PE with vasculitis. Some Charles Strauss. No, it's not. Addison crisis. No hemoptysis. Yes. BCB. BCB on top of HIV or immunocompromised. Sorry, I joined late. What is the case about? About short of breath, acute short of breath. Pets, new home, new job. This is for asthma. Yes, I agree, but it's not asthma. Also, the wheezes here maybe related to the asthma, sorry, to the pneumonia, but it will not be as wheezy. It will be like crackles, not wheezy. Patient immunocompromised, suspicion of HIV. Yeah, that's why I asked Dr. Aisha to screen for HIV in such case. In young and with chest infection, strange chest infection, you should screen about HIV. Okay. Examine for DVT. Okay. Some other question or comment. How can we explain wheezes, bronchitis? Okay. Is eye sign or patient for and her family? It, Dr. Abdullah said it's the hypopituitarism. Why CTPA no risk factor and less likely according to score? Yes, I agree also, but you can say if you don't find another differential, you can put in under category of acute short of breath or acute chest pain. Examination for DVT, yes. What the link between eye Addison hypothyroidism? Dr. Abdullah answered that. That's my question. Difficult and vague scenario, yeah. Also need to rule out autoimmune glomerular type 2 as both Addison and thyroid. Actually, from the picture, I suspect myasthenia gravis because of drop eyelid. I don't know why this picture also, why the patient has some eyelid problem. Pituitary tumor, adenoma, and take replacement. Okay, Dr. Abdullah, this is your case?
No,
Uh,
I'm sorry. It's the image.
okay.
Let me see the image again. It's not, no. There's no ptosis.
Okay, blind, you mean? I don't know.
Yeah,
I
blind.
see
Yeah,
some eye
blind.
problem.
Blind,
Okay,
bilateral. Yeah.
okay. You have the scenario now for you, okay? Why optic atrophy? Dr.
That's
Nora asked
something
you why.
congenital. Congenital.
Yeah, okay. Mr. Gillingham, 60-year-old man, reports several episodes of hemoptysis. Yeah, again, chest. Good to be in the same system. He has been treated for a lower respiratory tract infection, but symptoms persist. Assess the patient problem, address any position or concern raised by him. Patient information, Gary Gillingham, 60 years old. Okay, 2 minutes, Dr. Abdullah, then we'll start.
Ready, Dr. Abdul?
Yes, ready. Please set a timer for me.
Yeah, you can see the timer now?
Yeah.
Yeah,
Hello,
you can see.
my name Al-Malla. I am one of the medical doctors. May I confirm you are Mr. Gillingham and 60 years old?
Yes, I am doctor.
Mr. Gillingham, I hope you're not waiting too long for me.
Okay, doctor.
I'm here to take history from you and examine you, and I will try to address your concerns as much as I can. Could you tell me, it came to my knowledge that you have a problem of coughing blood. Could you tell me more about that, please?
Yes, doctor. I have coughing up blood once or twice daily for the past 3 weeks. Initially, there is only little streaks in my spit, but this week I coughing up a little more. And I went to my GP 2 weeks ago. He gave me some medicine for 5 days. It's antibiotic, and it didn't help.
I'm really sorry for what you're experiencing. Could you tell me, so did you have any such coughing blood before these 2 weeks?
No, doctor.
And is it with any, you see any like clots or like dark blood with it? Dark, like solid pieces of blood. Do you see with them?
It is always like my usual pilgrim, and it is streaked with blood. Recently, I noticed that is maybe just a blood when I cough.
And is it with mixed with the what color of sputum?
My usual doctor sputum, it is greenish white because I am smoker, but no any blood before these 3 weeks.
Okay. And is it getting worse or improving or the same since it started?
Worse, doctor.
Worse. Okay, I'm really sorry. And did you experience any such pain in your chest when you cough?
No pain, doctor.
Do you get any fever?
No.
What things that may worsen this coughing blood? Do you notice anything that make it worse?
No, doctor.
Anything that improves it?
No.
And did you have any such a feeling of headache, head sore?
No.
Okay. Do you get any runny nose or problem in the ears?
No.
Okay. Did you have a problem like in your dryness in your eyes or your nose or your mouth and saliva?
No, doctor.
Okay. Do you get any change in color in your skin, in your in anywhere in the body?
No.
Okay. Do you get any feeling of dizzy?
Sometime, doctor, yes.
Is it when you stand up or all the time?
I think all the time.
All the time. And did you have any do you have any feeling of being tired all over the body?
Yes, I noticed that I feel like I am not okay these weeks.
Is it a specific time of the day or all the time of the day and
All the
night?
time.
Okay. Did anybody tell you you are paler than usual?
No.
Okay. Any yellow color of the sclera?
I don't know.
Okay. Any sickness or do you feel any sickness or nausea?
Yes, slightly, doctor.
Okay. And is there any throwing up?
No, but just I feel nauseating and my appetite really affected.
Okay. Any sweats at night?
No,
Okay. Do you have any tummy distension?
no,
Any back passage fluctuation?
no,
Do you have any weight changes? Did you have your weight more or less in the past
yes, I
period?
noticed that I lost 5 kilograms in the past 2 months.
The past 2 months. Okay, I'm really sorry for that. Do you notice any double in your vision?
No,
Do you see problem in your vision?
no,
Did you have any weakness anywhere in your body?
no,
Okay, any tingling in the hands or feet?
no.
Okay, any urine getting dark?
Yes, I think maybe. I
Okay,
don't know, but I already reduced my intake.
okay. Do you mean the urine is getting tea-like color?
No, no, doctor.
Do you have any bleeding anywhere else in your body?
No,
No, okay. So do you feel any racing of your heartbeat?
no,
Do you get any short of breath?
no,
Okay. Any lower limb swelling?
no,
Okay. Do you have any joint pains?
no,
Any pigmentations or spots in your skin?
no, doctor.
Okay. Do you have any okay, can I ask you, do you face in the sun, do you see any skin like getting getting sore when you get in the sun, your skin, especially in the face?
No,
Okay. So you told me you took antibiotic, right, for that infection in the GP?
yes,
I'm sorry. Yeah. What do you remember the name of the antibiotic?
amoxicillin,
Amoxicillin. How many days?
5 days.
5 days. Okay. And did you feel any? You didn't change, I suppose. It's worse, right?
Yes,
Okay. And you told me you have fever. No
no.
fever. Okay. Okay. Did you have a travel history?
Uh, my last travel, doctor, 6 months ago
6 months ago. Where?
to Spain.
Okay. And do you have a recent surgery?
No,
Okay. And can you tell me if any in the family do you have like having similar problem of coughing blood, similar
no,
issue in the family?
no
What
one in my
family?
family unwell.
And no conditions run in the family.
No,
Any heart issues in the family or in the lung?
no, I think no.
I'm sorry for that question. Yeah. And did you have? Can you show me your medication list?
No any medication, doctor.
Okay. Do you take over-the-counter medications?
No,
Okay. And I'm sorry for that. No illicit drugs at all.
no,
Do you have any needles history? I'm sorry for that question. I'm really sorry, but I asked too
no,
many patients that
no,
question.
doctor.
Any history of out of the do you have multiple sexual partners?
No, doctor.
Okay. And so what do you do for a living?
I am retired, doctor.
And why is that, can I ask?
I am just retired recently
Yeah.
from working as lawyer.
Employer.
Lawyer,
What?
lawyer.
Lawyer. Okay, okay. And so how whom do you live with now?
I live alone, doctor, with my Bobby.
With your what?
Bobby,
I'm not listening well.
my dog, my dog.
Okay, and how much are you impacted by this illness?
Okay, just I feel just I'm bothered about this blood, and I am worried about.
Yeah, I'm really sorry. I will do my best to
But I am
try
okay. I
to.
still do exercise and walk my dog
Okay.
every day.
Okay, good. And could you tell me if do you have any allergy to any drug
No,
that you know? Okay, so may I do you have any past history of surgeries?
no, doctor,
Any past history of any medical condition in the past?
no.
Okay, and may I examine you?
Okay,
So any specific picture of the face or any is there any deformity?
no deformity.
Okay, and I want to look to the hands. Any clubbing? Oh, first the vitals. Any abnormal vitals?
No, the vital all normal, blood pressure normal, pulse equal
Okay.
and
Okay.
60. Okay.
Okay, and I have to look to the hand. Is there any clubbing or
There is finger clubbing and there is staining on the finger
staining of what?
of finger. Nicotine staining.
Staining. How many cigarettes do you smoke, Mr. Gillingham?
Yes,
How many cigarettes?
20 cigarettes per day,
For how long?
40 years.
Okay, well, smoking is quite dangerous in your health, and we are quite ready to help you with support of cessation. Is that all right?
Okay, doctor, I'll try.
Do you drink alcohol?
No, doctor.
Okay, so I need to look to the any pulmonary erythema, any
No.
splinter hemorrhage. Okay, and any atrophy in the hands.
No.
Okay, I will go to the check any in the eyes, pale or not, any jaundice or
No.
not.
No.
Okay, in the mouth, any ulcers? How's the
No.
mouth clean? Okay. GVP,
Normal, not raised.
cervical lymph nodes.
No cervical lymph nodes.
Okay, and I will listen to the chest. It's
Okay.
chest expansion. How is it?
Okay, it is hyper expanded chest.
Hyper expanded. Okay, and is there any wheezes, Mr. Gillingham?
Yes, there is occasional expiratory wheezing on both sides.
Okay, I will. Do you get? Do you have like something making you like pets at home? You have the dog. You said. Do you feel you are
Yeah.
more comfortable when you are away of the dog?
No, doctor.
Okay, and so I want to percuss quickly on the chest.
Okay, hyper resonant both sides.
I will. The trachea is central.
Central.
I will listen to the chest.
Okay. No any added sound. No. No crepitation. Just occasional wheezes.
Okay, and the abdomen. The abdomen is no organomegaly.
No need. No need for abdomen.
Okay, lower limb swelling.
No limb swelling.
Okay, Mr. Gillingham, what is your concern?
Is it cancer, doctor? I wrote on the internet about my symptoms.
It's a good question. I appreciate your question. It's quite one of our suspicions. I'm really sorry for that, and we need to admit you for your symptoms to run more tests and scans and images. And we need to exclude the possibility of cancer, and we need to do some test called a blowing test that you blow by your mouth. Any other concern?
So I should stay in hospital, doctor?
Yes. Okay.
Okay, doctor.
Okay, time is up. Yes.
Thank you.
Okay.
Okay. So what is your differential, doctor?
My differential, okay, 60 years old. So my differential is this gentleman is first. My differential is a CA lung. Second, from the heavy history of smoking. And second differential is
First
chronic
differential, what?
obstructive.
Sorry, again. First differential
Chronic
is
list of differential is CA lung
cancer,
cancer.
يعني?
Yeah.
Okay,
Second differential is chronic obstructive pulmonary disease.
okay.
And third differential could be acute infective exacerbation, so trigger the chronic obstructive pulmonary disease.
Yes. So pneumonia, okay. Other
Possibly
differential?
the least in the differential is pulmonary embolism, because the patient's hemoptysis.
But no chest vein. Okay. So
Yeah,
what is your plan if you admit this patient?
So okay, my plan is that I need to educate. So I need first to educate. I need the patient about what are the possibilities of his coughing blood, and I need to we need to run basic investigations, blood count, look to exclude any anemia as a reason of his dizziness, and after this coughing blood, we need to look the inflammatory markers to exclude infection, white blood cell, and C-reactive protein, and looking if any vasculitic or autoimmune related conditions. So ESR may give a hint about that, and autoimmune profile, but that's least benefit. So then on the top of importance is a scan of the CT thorax, abdomen, pelvis to exclude any cancer or metastatic lesion suspicious, and in the thorax it will be high resolution CT chest, and also
you will take urine analysis for this patient?
we'll need sputum culture and sensitivity. No, not initially. I'm not sure about the urine test. Urine analysis to screen of infection, yes.
Other than infection? You mentioned that you will check for, yeah.
Yes, because the patient has history of he mentioned transient dark urine, so I suppose urine test to exclude any kidney affection by the proteinuria or glomerulonephritis, glomerulonephritis with hematuria.
Okay.
So yeah.
Okay. For this patient, if you suspect that he has cancer, what type of cancer he may has?
So he may have a small cell lung cancer or a squamous cell lung cancer.
Yes, perfect. So what is the gold standard for diagnosis of squamous? If this patient has hemoptysis?
Yes, he will require a bronchoscopy.
Yes, excellent.
After educating him, well, yeah.
Okay, thank you. You did well, Dr. Abdullah, mashallah.
Really?
I
Thank
comment? Yes, you reached the
Yes,
diagnosis.
thank you for the test, Dr. Aisha. You can comment now, yes.
Sure.
Yes, you reach the diagnosis, and I think you screen the history good. Just some small point you will miss about history of TB. You should mention in this patient. You should ask about traveling in endemic area or born outside the UK, and anyone has TB in our surrounding, and if he has TB before when a child or when adult. So you must catch the TB in this patient. Let's say first, if you has hemoptysis from outside, this will be easy because hemoptysis, you narrow the differential. So maybe you'll enter the case and we have your differential from start. The hemoptysis is narrow cases. You will consider pneumonia, neoplasia, TB, embolism, bronchiectasis, vasculitis, and pulmonary hemorrhage. That is Godbuster also. So it is like vasculitis also. Okay. So if you has this all in your mind, you will ask about it good, and you will find the case will guide to one of them. And if not guide, you will just mention all in your mind to the examiner. Okay. So the TB is one of the second differential in this case. The first is cancer. Yes, he is old age and he has hemoptysis only 3 weeks, and he has like lost weight, and some also here mentioned that he nauseating and feeling sick, being sick, and this is may guide to any paraneoplastic specific to squamous. Maybe he has like hypercalcemia, and also you can ask about SIADA for lung cancer, neoplastic, asking about neoplastic syndromes, that the common ones. It may be must, because you may find some of them, especially the SIADA and hypercalcemia. Okay. Myasthenia may be also, and you should mention also you will investigate for these paraneoplastic syndromes. Okay, because it is common in lung cancer. They count it for about 10%.
You mean Lambert-Eaton syndrome, right? Myasthenia as Lambert-Eaton.
Yes, Lambert-Eaton, yes. Not the myasthenia gravis, yes. And it has specific test also. Okay, for other thing in history, I think he like he cover all, just the paraneoplastic and the TB. Okay.
Yeah.
Okay, for the examination. For examination, you will go, yes, for general look and inspection, for respiration, if you have any accessory muscle of breathing, so in stress or no, and respiratory rate. You should ask any case of chest, you should ask about pulse and RR. Okay. For hand, yes, you ask about all, just the retention flap, because he is heavy smoker for a long time, you may find, so you will ask to do retention flap, like extension of the hand, like as you see the tremors. Okay. And also the wasting is very good point, the clubbing and the staining. And you will look for Horner syndrome because you suspect lung cancer. So just rapid, if you see the face, you will see the tongue. So just rapid screen for Horner, like close your eye and bench your teeth like that. You will see the tongue for cyanosis, and you may find trachea for position and the lymph node. This is very important. And also supraclavicular, do not miss it. Okay. Not only cervical. And axillary also you can examine. You will ask the examiner, and then he will tell you no need, but you should ask. For the chest, it is case of chest, so we will do all chest examination. We will see the inspection and expansion, then percussion and auscultation. You may find consolidation, you may find effusion, you may find the collapse. So put this all in your mind. In some cases, there is come with collapse, so you will find the trachea shifted. For lower limb, you'll see the edema, and also you will show the examiner, you check for DVT by temperature and by inspection. Okay. And also by trying to see the diameter of both legs. And just to see the example that you not checking only for edema for this patient because embolism in one of the fringe. For the test, you will do for basic, and you should mention the INR in this patient because you will maybe he will need platelet, he will need he can anytime enter in marked hemoptysis and frank hemoptysis. So you should do INR on admission, and you should also do calcium because we said that it is paraneoplastic. Anti-GBM, this is for lumbar eton, and urine analysis, it is a must in any chest cases that the chest and renal is connected in good Buster and in Wigner, okay? Or glamiotosis periangitis, okay? Chest X-ray also and CT staging, as you said, sputum culture, and also alpha-feto, what is this? Sorry, what is this? For TB, yani, examination for the sputum for TB, okay?
AFB.
Yes.
Acid fast bacilli.
Acid fast, yes, okay. For management, you should mention to the examiner, I am urgently will include rapid access to the respiratory clinic for rapid bronchoscopy, and in admission, we will include the smoking cessation clinic in the management, and you will, as you said, also we will check for blood if he need urgent blood, if he need any now replacement of blood or no. I think this is all about replying about cancer. Not really the one you will not. I am happy with this question, or it's good to ask this question because this is really to be sad when you tell him. You will reply. I think, يعني you reply like, well, Mr. anything, Mr. مثلا Ali, I am so sorry to tell you that your condition has the high probable, okay, to be cancer, and we will run a rapid test for that, and we will inform you about the result as soon as we can. So you will be sorry, and you will tell him directly about what you think, because it is highly suspected to be cancer. So you will not like give the patient that it is one of possible causes of this condition. It's your high possible, so it is really you have a high possibility of this. Just you will reply like this. And they comment a lot with one candidate, a lot of candidates about this, about to reply away from the truth. So if you have this is off the top of your differential, you should tell the patient that it is the top of your differential.
Yes.
Okay. This is all.
Okay, thank you. Yeah, thank you, Dr. Aisha. Nice case, and well done, Dr. Abdullah. You catch the diagnosis, but I think the case was clear, not like your case.
Yeah,
So,
yeah. Thank you. Nice case. Yeah.
Yeah, it's common also in the exam, and
Exam case,
you can
actually, typical, yeah.
catch it. Yeah, you can catch it from the constitutional symptoms and the chest symptoms, as we saw. Patient is having loss of weight and night sweat, so it's clear as cancer, along with the history of smoking or heavy smoking. It's also one of the predisposing. But I want to ask Dr. Aisha, what is the relation to the dark urine? Why dark urine?
He may mention to him to ask about Sayada symptoms.
So
if you have
Sayada, the urine will not be as concentrated, you mean?
concentrated, yes, concentrated.
Yes,
Sayada they are
means
concentrated. Inappropriate ADH a
yes,
lot.
inappropriate. A lot of antidiuretic. Okay. Yes, but I think it's not that much concentrated. Anyway.
Maybe
so
because I may try to guide him to ask about others. And especially this is dark for his, because he is dehydrated. He can't eat good for 2 months, and he has nausea. Like he really has hypercalcemia, not has sciatica. But just I mentioned to try to
Yes, you are
focus
trying
on
to, yeah,
yes.
to correlate. Okay, but yeah, as you said, as squamous, the calcium only will be high. Then it will be different presentation to the urine, as for example, the calcium stone and some water or hematuria. If calcium, I mean, if hypercalcemia
It will be polyuria, yes.
squamous cell.
Hypercalcemia, it will be
Yes,
polyuria, yeah.
and if squamous,
Seriously.
it will not be as with sciatica. Sciatica will be with the other one, small cell.
Yes.
Okay.
Really, yes, but
Yeah.
it is not a rule. يعني when I search it is
You
not
mean
a rule.
both types? Both
لا،
types can
في
be
اليورين ما
present?
بيلقى الصوديوم يا دكتور. باسم معلش. في
Sorry?
السيادة بنلقى الصوديوم في البلد لو أو هايبو،
Yes,
لكن في
low
اليورين
sodium. Yeah,
بيكون
yeah.
هاي، بيكون هاي تقريبا، هاي صوديوم بيطلع كله في اليورين.
Yeah, because the water, no, the urine is concentrated. So
أيوة.
high sodium. Yes,
أيوة
high
هاي
sodium.
صوديوم.
Yes, high sodium. Yes. But again, I think this is also my opinion. Is or does the sciatica or small cell associate the squamous cell? I don't know. Unlucky patient or what? Because I never heard about two pathology or two underlying cancer in the same
No,
lung or the
I
same
don't mean that. I
النن
mean that is
النن
any cancer can has paraneoplastic in the lung. Even
النن small lung cancer هي الماشية مع السيادة.
Yes, I agree. It will be both calcium and sciatica in same patient, or small cell and non-small cell can be like
لا
this.
لا أكيد طبعا.
Yeah, I think the pathology it will be only one pathology. I mean.
yes,
Anyway,
yes, I know,
as a
but we don't
you
know
put it
exactly the patient
yeah,
hemoptysis from squamous
maybe
or
you put the case for teaching purpose to learn from it. I mean, but in the practical life, it's rare to have two pathology in the same lung or in the same patient. Anyway, let's
this
comment.
patient not have sciatica, no any symptoms sciatica.
You told me there is
هي السكوينس ماشية مع الهبوة تقريبا، صح؟ اللي هو الهايبر ما بعرف شنو ذيك. لكن السيادة بتمشي مع ناس النون سمول اللي هو مع الاندوكراينولوجي تقريبا.
Yes, squamous with the small. Okay. Anyway, let's comment from the start. Dr. Abdullah, I think the case was clear, straightforward, and the constitutional symptoms will guide you to the case, along with the chest symptoms and the coughing of blood. And initially, it was streak of blood, and then it will be like fresh blood, as you said, Dr. Aisha, because of cancer, and the cancer might invade some blood vessel, and it will be fresh blood. And sometimes the patient will go through acute presentation of hemoptysis, and it can be life-threatening one. Some patients need embolization, and others might reach to surgery and lobectomy or whatever the reason of the blood vessel bleeding. For the history, yes, we'll take the system review, especially three systems, as Dr. Aisha said. The cardiac, the most related or relevant system to the chest. First, the chest, cardiac, and renal. All these will be affected by any means, either as a syndromic disease or as indirect to the heart failure, or heart failure with complicated PE, pulmonary hypertension. So both of them can lead to each other. The renal will be as Churg-Strauss or Goodpasture, or the other condition, eosinophilic granulomatosis polyarteritis. So these are the three symptoms. Okay, this is the system review in this patient. Smoking and social is very important as well, along with the job. And as Dr. Aisha said, there is also some pet or some animal in the home, just to distract or to guide.
I don't know. This is a scenario I have.
Distracted. Yes, yes, no problem. It's distracted. No, by the way, some words in the history can
Maybe if
distract
he
you.
will admit, he will ask about the dog. I don't know.
You should ask. It's okay to ask. It's not something not important. You can ask, and
Yes,
it's
he
important
mentioned
to
in
ask.
scenario to he asked about admission because this, but no time, so I didn't make this point in the scenario.
No problem. It's okay. Some in the chest, you should ask about this animal and pet or birds. It's related, by the way. It's not something not necessary. It's necessary to ask. Okay, because in the asthma, for example, you should ask all these questions. So make it as a habit. Ask all these questions in the chest symptoms patient. Okay, along with the contact with the sick people or chest person or to travel history to endemic area for TB or other chest condition. This is for the social and occupational. Then the examination target, as Dr. Aisha said, the hand for all system or the signs in the hand, like clubbing, staining, nicotine staining, and tremors if severe respiratory failure. Along also with the respiratory rate and vital chart, you can ask all. The chest system will be examined full or complete or yes, full chest examination, starting by inspection palpation, percussion, auscultation, along with lymph node, of course. I think this case is clear and straightforward. Dr. Abdullah did great. The differential will be, as we mentioned, the cancer lung, and you can put also TB. You can put PE and other syndrome with the hemoptysis, but again, it's that no other kidney affliction. You can also put as a differential HIV, but again, it's HIV, no risk factor for HIV. This is our case for cancer lung. Any question, any comment? Yeah, could be acute kidney injury, could be due to dehydration, yes, can be. Pulmonary function before surgery. Blood gas also be a habit to ask about arterial blood gas for any chest complaint as a bedside test, okay? But along with pulmonary function test, restrictive or obstructive beta. Any question for this case? By the way, what's important in blood gas for patient, in this patient? What's important? Someone can answer this question. Difficult question. What's
For pulmonary
important?
embolism, I think.
Okay, if you suspect primary, what else? It can guide you to the case in the blood gas.
Maybe the hyponatremia or what?
No. Okay, blood.
Hyponatremia.
Okay, hyponatremia, you can find it in the electrolyte and in the chemistry. But in this patient, you might have something in the blood gas. You will not see it in another test.
About heavy smoker, maybe we
Yeah,
find
yes.
respiratory
Excellent.
acid.
Okay.
Yes.
No, it's heavy smoker in the blood gas. What you can find? Heavy smoker, blood gas.
Respiratory acidosis.
Heavy smoker and the blood gas.
Compensated head. Maybe low
No.
bicarb.
Heavy smoker
High
and the blood
bicarb.
gas. CO2 retention. No. Yes. Someone. No, not CO. Not CO. CO for the
respiratory alkalosis, صح؟
no, I'm not talking about
respiratory
not
what?
about pH. Something like CO
saturation of
hemoglobin.
oxygen يعني oxygen
No,
SpO2
no.
oh
It's methemoglobin.
yes
Okay. Not CO. CO for the burn or smoke. Not smoker.
for the car.
Yeah. The level of methemoglobin in the patient in the blood gas. It can give you a hint of the patient smoking. Okay. I'm little sure about meth or CO. I'm sorry, maybe I mixed. Yes, not lactate. It's CO. Yes, CO. I think CO also in the blood gas. So I mix.
CO or yes.
Let me wait. Yes, it's CO. Yes, you're right. The one mentioned the answer. Yes, CO. And the level of CO. Who knows the level of CO? Yes, it's CO. CO hemoglobin. How much in the smoker to diagnose? No, above 35. So high number. No, it's not 35. Non-smoker more than 3, and in a smoker more than 9. Okay. Okay. Yes, 3 in non-smoker. Yes, 3 in non-smoker, more than 3. But in smoker patients, it will be higher than it reach more than 10 or 11. It'll be maybe yes 30, number like 30 or high as 30. Sorry, if I mix the methemoglobin will be with another patient nitrogen toxicity. Okay.
Okay.
Any other question? Any comment? Nitric oxide, yes. Any question? Any comment? Thank you for waiting this long. If no question, we can end this session. We'll see you tomorrow, inshallah. Thank you, Dr. Abdullah, Dr. Aisha, and all colleagues who comment and share with us the comments. Yes, thank you all. Thank you, Dr. Aisha. See you tomorrow, inshallah. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.